Hi, and welcome to today's session, Digestive Enzymes for FODMAPs. I'm Jocelyn Wells. A registered dietitian with a specialty in GI nutrition. I'm part of the team at FODZyme, the makers of a digestive enzyme for FODMAPs. In my role, I support our community of healthcare providers through educational programming, research, and product communications. I want to be fully transparent and clear in my disclosures today. Since I work for a company that makes digestive enzymes, this is of course a conflict of interest you should be aware of. However, I'm also a clinician, and in my role, I have developed a deep expertise on this rather nuanced topic, so I do also want to share my knowledge with you. So diving right in, here's what this session will cover. We'll start with a recap on IBS symptom pathology and the role of FODMAPs in IBS. We'll also review various dietary approaches for management of FODMAP intolerances, both dietary and non-dietary, and key considerations for patient assessments. We'll go over the science behind how digestive enzymes for FODMAPs work and spend plenty of time on clinical application so you're prepared to support your patients. So just to set the scene, I want to start with a background on IBS to underline how truly complex IBS is. What we know is that there are many factors that lead to symptoms in IBS. Symptoms can be related to motility issues that lead to changes in how food moves through the digestive tract. They can be related to hypersensitivity, so an increased sensitivity to any kind of digestive processes or sensations, even those that would go unnoticed in patients without IBS. They can be related to altered immune function and increased inflammation along the digestive tract, as well as general alterations in the composition of the gut microbiota, also sometimes referred to as dysbiosis. What we also know is that about 3/4 of patients with IBS will generally see a symptom improvement on a low FODMAP diet, suggesting that FODMAPs are contributing to symptoms in most patients. So FODMAP-targeting approaches are generally very important to consider when it comes to symptom management for IBS. So let's just do a quick review on how FODMAPs tend to cause issues. FODMAP is an acronym for several families of short-chain carbohydrates that are poorly digested or absorbed by the gut. Instead, they draw water into the digestive tract and are fermented by gut bacteria in the colon. For those who are FODMAP sensitive, this can lead to common digestive issues like gas, bloating, constipation, and diarrhea. What's important to remember when it comes to helping patients identify and manage FODMAP intolerances is that these symptoms generally occur 4 to 8 hours after a high FODMAP meal or food is eaten. This is because it takes time for the FODMAPs to reach the colon and for this osmosis and fermentation to occur. I highlight this point because the timing of symptoms can be a really helpful clue when you're helping patients figure out what their digestive triggers might be and if they're FODMAP sensitive. When a patient comes to you reporting they need to rush to the bathroom, say 20 minutes after a meal, that's a helpful indicator for you that FODMAPs are likely not the primary culprit for their symptoms. However, if they're reporting lower GI symptoms late at night, maybe 4 hours after dinner, that can be a really strong sign to probe further into the hypothesis that they may be FODMAP sensitive. In addition to IBS, there is a high overlap in FODMAP sensitivities and other conditions. Emerging research shows that FODMAP sensitivities may also be present in these conditions and even more. Some examples include inflammatory GI conditions such as IBD. Research is also looking into how these FODMAPs may be troublesome in those with SIBO, PCOS, endometriosis, GERD, different types of colitis, and even following gastric surgeries. There are still a lot of questions on why we're seeing a potential overlap in FODMAP intolerances in these conditions. The mechanisms are not fully understood, but they may be related to the high prevalence of comorbid IBS in these populations, or potentially other inflammatory or immune-related factors such as dysbiosis that may also be present in these conditions. We also know it doesn't take a formal medical diagnosis to be FODMAP sensitive. Many athletes consume high FODMAP diets, and some notice FODMAP intolerances will hinder their performance. Even among, quote, healthy patients, excessive FODMAP intake can trigger symptoms, and there are plenty of patients who may say, oh, I can't eat onions, or garlic is a trigger for me, which we as clinicians can note as a strong indicator that they may be FODMAP sensitive and could benefit from interventions that are addressing FODMAPs. So I put a question mark on this page just because this is where the research is focused right now, but there's lots more to learn, and our understanding of the relationship between FODMAPs and conditions outside of IBS continues to evolve every day. So let's get into where FODMAPs are actually found in our patients' diets. FODMAPs are just about everywhere in the foods we eat. So it can be really hard and frustrating for patients when they're told they should try to cut back on all these foods. It can feel like there's nothing left to eat because FODMAPs can be so hard to avoid, especially if someone is not very involved in deciding what they're eating in the first place. Say they're not the one in their family who prepares meals, or maybe they rely on food from a cafeteria. And then not only are FODMAPs prevalent in most diets, they're also found in many highly nutritious foods. So, all to say, we don't want patients to be limiting FODMAP containing foods any more than they need to in order to control symptoms. It's also exciting to see how there's been a good amount of research in the past few years on which FODMAPs specifically are triggering an IBS. Fructans consistently come out as the most common trigger. Different studies will arrive at slightly different numbers in terms of prevalence, but these trends are generally consistent. Oligosaccharides, so fructans and galactans, are really common triggers in IBS. These are the O in the FODMAP acronym. Oligosaccharides are also the FODMAPs that are prebiotic fibers, so they do provide particular benefit for gut bacteria when they're fermented. But this fermentation is also what can lead to gas, bloating, and other symptoms. So we want to help patients eat oligosaccharides like fructans, so the garlic, onion, other alliums, wheat, and Brussels, as well as the galactans, so beans, nuts, and legumes. We want to help them have these foods as they're able so that they can get these prebiotic benefits. Then moving to these other categories, the monosaccharide FODMAPs, so fructose and polyols, which include sugar alcohols like sorbitol and mannitol, are more likely to be osmotic and draw water into the colon. And then the disaccharide family, or lactose, can be both osmotic and lead to fermentation and gas. I also thought I'd share a little more specifically on fructans because there are a few types you might see mentioned in the literature or on food labels. Fructans is the general term that includes several types of oligosaccharides, which can have varying chain lengths, structures, and different types of linkages between each monosaccharide. Inulin is a highly common type of fructan that's made of long chains of fructose units with a terminal glucose. Inulin is found in a variety of plants and often used in food and nutrition supplements or drinks to add prebiotic fiber. In addition to inulin, levain is another type of fructan, which has a different type of linkage between the fructose units than inulin does. Other members of the fructan family include fructooligosaccharides, so FOS, which are shorter in length than inulin. FOS is also sometimes used in supplements to add fiber. These different types of fructans are all found in common plants, and most plants actually contain a mix of different types of fructans. It's interesting to know that genus, species, seasonality, and environmental conditions all play a role in influencing how much of each type of fructan will be present in a particular fruit, vegetable, legume, or whole grain. So, all to say, again, there's nothing inherently bad about FODMAPs. I always encourage people to remind patients that FODMAPs do not cause permanent damage or harm to the digestive tract. We don't want to create fear of FODMAPs since they are simply just naturally occurring carbohydrates that have health benefits. It really is worth making clear to patients that the issue is just that in those with sensitive digestive tracts, FODMAPs will create heightened digestive sensations when they're consumed. When it comes to managing FODMAP intolerances, the low FODMAP diet is an effective tool. I'm not going to go into it in much detail here, but just as a brief recap, the low FODMAP diet is a three-phased approach to help patients figure out whether FODMAPs are triggering for them, to learn their FODMAP triggers and the amounts they tolerate, and to develop a long-term plan that's sustainable and controls their symptoms. However, the low FODMAP diet can be very restrictive and burdensome, so it will not be appropriate or feasible for all patients. Some may instead benefit from a targeted simplified FODMAP diet, which just eliminates the most common FODMAP triggers, like milk, wheat, legumes, garlic and onion, cauliflower, mushrooms, and some of the less tolerated fruits, like stone fruits and fruits high in excess fructose. While this approach is less restrictive, it is still complex and should be implemented with the support of a registered dietitian. Another way to approach FODMAP restriction is bottom up. The traditional FODMAP elimination diet uses a top-down approach, which is here on the left. Over the last few years, another method that is increasingly used is this alternative bottom-up approach, which you see here on the right. A bottom-up approach starts with restriction of just the most commonly triggering FODMAP families, the oligosaccharides and lactose. This means patients cut back their intake of foods high in fructans, GOS, and lactose. After patients reduce just these FODMAP groups, you then monitor response, and then, if patients haven't achieved adequate relief, they then move on to restrict any additional FODMAP groups as needed. From there, your goal is to be able to narrow in and identify their triggers or refine as necessary. This bottom-up approach means they don't need to start by restricting all FODMAPs. They can just start with a few and then add additional restrictions only as needed. These new approaches are coming out of an increasing recognition of how restrictive diets like low FODMAP can have negative consequences, especially if patients do not reintroduce enough foods or start developing fear and anxiety around trigger foods. These are just a couple examples of why diet restriction needs to be implemented mindfully. First, a low FODMAP diet can be low in fiber and particularly can be low in prebiotic fiber, which supports healthy gut bacteria. FODMAPs are present in many fiber-rich foods, and we know a typical diet is already low in fiber. So this means a low FODMAP diet may further reduce fiber intake, which can be harmful for the health of the gut microbiota. If not implemented properly, a low FODMAP diet is also associated with increased risk for nutrient and energy deficiencies. Here, iron, calcium, and protein are of particular concern. Following a restrictive diet can also be socially isolating and create anxiety or fear around food. In some, this can increase risk for disordered eating behaviors. And lastly, low FODMAP foods and diet modifications at restaurants can be really costly. Some research suggests that low FODMAP foods can be as much as 2 to 3 times as expensive as their regular counterparts. So these potential side effects have led to increased discussions on who a low FODMAP diet might be appropriate for. This is from a recent review on dietary management of IBS. It does a great job of laying out the advantages and disadvantages of supplement and diet approaches in IBS. I'll just highlight a few here that are of particular importance for the low FODMAP diet. These are truly just considerations for you to work through with patients as you're developing the right approach with each of them. One challenge that often arises with patients trying to follow a low FODMAP diet is the difficulty it creates in following cultural or religious diet practices. In some cultures, a lot of staple foods or food groups can be high in symptom triggers like garlic, onion, and legumes. This makes personalizing an approach really important for these patients, both in order to prevent social isolation as well as to support adherence to whatever plan you have developed with them. This can be an advantage of a diet approach because you can customize the diet recommendations based on their preferences. But if you're unable to tailor the plan enough that it's going to actually reduce their symptoms, you may also want to consider a supplement approach, which would allow them to continue to eat their current diet while adding in a supplement that can help manage symptoms in a targeted way. A lot of interesting research has also been conducted in the past few years on food-related quality of life in IBS. And we're learning just how much less diet satisfaction patients with IBS have than those who aren't managing a chronic condition. When research compares patient satisfaction levels around the different diet approaches used in IBS, like low FODMAP, gluten-free, or general healthy eating guidelines or Mediterranean guidelines, patients consistently prefer less restrictive diets and find them more affordable, less time-consuming, and easier to follow. So we want to do what we can to allow patients to eat a more liberal, balanced diet, which sometimes means offering a targeted supplement option alongside a less restrictive diet. Another factor to consider that this paper lays out really well is the education required for each category of intervention. Diet approaches generally require more understanding and education on the provider side, as well as more education delivered to the patient. The low FODMAP diet is highly complex and requires a provider to be well trained in its nuances to deliver it well. Plus, it takes a lot of understanding and motivation from the patient. Supplement approaches can be a lot easier to implement from this perspective because they require less education and time from both providers and patients, and they interfere less with the patient's daily life. So it's not to say at all that we shouldn't be doing everything to educate providers and patients, but sometimes due to time restraints or a patient's comprehension level, we do need to be realistic about what's feasible. There's a ton more to go over here, so I encourage you to look up this paper. It's a really great resource, but for the sake of time, I will keep going. While still very new, researchers are beginning to discuss a new 5-phased FODMAP framework. This updated approach includes a new phase 0 to identify ideal candidates for low FODMAP based on predicted response and their clinical picture. Plus, it also suggests a new phase 4 to implement adjunct diet and non-diet therapies. It comes out of this increased awareness of just how important it is to be properly screening patients for restrictive diets and the awareness that excessive dietary restriction has serious health risks. So I want to be clear, this framework is just in the early stages and proper guidelines for its implementation in practice does not yet exist, but it is starting a very important discussion on the potential drawbacks and consequences of overly prescribing restrictive diets like low FODMAP. This is also from a great research paper that outlines the patient profiles that would be suited to various FODMAP approaches. For some who are highly motivated and have the time and resources, the traditional low FODMAP diet might make sense and be the right approach. For other patients with fewer resources or interest in less restriction, you might want to use a simplified approach. This is often the case with those who are clearly eating very high FODMAP diets and can likely get a lot of clinical benefit through just a few targeted dietary changes. Others who might benefit from a simplified approach could be those already on a restrictive diet for other conditions, the elderly, and children. Those who would be unlikely to implement a low FODMAP diet properly due to their preferences, lifestyle, or mental capacity might also benefit from a more simplified approach. There are also a few additional contraindications for the low FODMAP diet that weren't on that list, but I do want to share. This includes anyone with a history of or current disordered eating behaviors, as well as those at risk for them. It also includes highly picky eaters, where cutting out foods might leave them with very few options. And lastly, it also includes those who don't have a formal IBS diet. This is because a restrictive diet like low FODMAP can both compromise nutrition status and have negative psychosocial consequences. So it's important that patients have that IBS diagnosis before you're considering low FODMAP with them. So that was a brief overview on FODMAPs and some of the considerations for dietary approaches to support patients in managing FODMAP intolerances. It also brings me to our next topic of discussion, digestive enzymes. I'll start with a background on digestive enzymes and how they work. Then we can get into the research on how they're used to help patients based on their personal levels of FODMAP awareness and indications. So to start, what are digestive enzymes? At a high level, all enzymes are simply specialized proteins, so chains of amino acids, that are folded in particular ways to catalyze reactions. Digestive enzymes are a subcategory of enzymes that are designed to act on troublesome foods, such as FODMAPs, to break them down. Digestive enzymes also exist that can target fats and proteins, though our focus today will be on carbohydrate targeting enzymes. Here I've also listed examples of carbohydrate substrates and highlighted those that are FODMAPs. Next to each are the enzymes that would be targeting each carbohydrate. Enzymes are highly specific to their target, so each active enzyme would only be working on a single substrate. And when it comes to today's focus, FODMAP targeting digestive enzymes, there are a couple points that I want to highlight. The purpose of digestive enzymes for FODMAPs is to break down the FODMAPs that are present in the foods before these FODMAPs can trigger symptoms when they reach the lower half of the digestive tract. I use the analogy that digestive enzymes act as specialized molecular scissors to break down FODMAP molecules, making them easier to digest. This can be a helpful way to explain how digestive enzymes improve tolerance to FODMAPs when you're discussing how enzymes work with patients. Examples of enzymes that break down FODMAPs include lactase, alpha-galactosidase, and fructan hydrolase. You may also sometimes see intolerances mentioned. This is a more narrow form of a fructan-targeting enzyme that would just be targeting the inulin type of fructans, not the full fructan family. Glucose isomerase, which can also be called xylose isomerase, is an enzyme for the FODMAP fructose, though it's not breaking down fructose but rather changing its structure to glucose. What's also important to note is that, with the exception of lactase, the body does not produce enzymes that target FODMAPs. When it comes to, quote, normal FODMAP metabolism in those without FODMAP intolerances, FODMAPs are either metabolized by the gut bacteria without triggering symptoms, or they simply pass through the digestive tract entirely and are excreted. FODMAPs can become an issue in those with sensitive digestive tracts, often seen in IBS, when they get fermented. Because the gut bacteria are partially responsible for metabolism of the oligosaccharide FODMAP families, those fructans and galactans, FODMAPs can be particularly troublesome in those with dysbiosis. So for these folks, digestive enzymes can provide extra support against the symptoms that the FODMAPs might otherwise trigger. So all to say, in quote, healthy individuals, FODMAPs are generally metabolized by gut bacteria or simply pass through the digestive tract without notice. It's only in those who are super sensitive to FODMAPs that the symptoms arise, and we want to find ways to help patients better tolerate these high FODMAP foods. So moving on to recommendations on using enzymes with patients. Clinical guidelines on how to implement the low FODMAP diet, as well as guidelines from Monash University, recommend using digestive enzymes to support FODMAP tolerance. For anyone new to Monash's work, Monash University is the leading research institution on FODMAPs and the low FODMAP diet, and provides many trainings for providers and patients on FODMAPs and dietary approaches to manage FODMAP intolerances. Their guidelines suggest using digestive enzymes for management of GI symptoms related to FODMAPs, such as bloating, gas, diarrhea, and constipation. They also highlight the benefits that enzymes provide in terms of dietary flexibility and reduced anxiety in social environments that involve food. Their recommendations are to use enzymes as needed to develop a long-term, sustainable diet and expand food choices as much as possible. This helps patients not only meet nutrition needs, but also helps ease the burden of following a restrictive diet long-term. There's a solid body of research supporting the efficacy of digestive enzymes for FODMAP intolerances within the IBS population. Research shows that patients with carbohydrate maldigestion and malabsorption experience fewer symptoms when consuming otherwise triggering FODMAPs with digestive enzymes. Lactase has long been used to support digestion of lactose-containing foods. Research shows that lactase helps manage symptoms like bloating, abdominal pain, and gas in lactose-sensitive patients. Data is slightly more mixed when it comes to GOS targeting enzymes, but among those with IBS, alpha-galactosidase has been shown to prevent bloating and gas associated with high GOS foods, like beans and legumes. Outcomes with fructose targeting enzymes for IBS are more mixed, and there is little consensus on their clinical value, though in practice some patients may find them helpful. Across the board, studies looking at the safety of lactase, alpha-galactosidase, xylose isomerase, intolerances, and fructan hydrolase show they are safe and low risk. Preliminary research on multi-enzyme blends also shows promise. Early data suggests they help manage both overall GI symptoms as well as specific symptoms related to FODMAPs like gas, bloating, diarrhea, and constipation. Some of these studies also look at mental health or quality of life measures, and these studies saw that digestive enzymes provided psychosocial benefits, such as reduced food avoidance behaviors. So there's lots more research to be done here, but among the findings that are out there, data does support using digestive enzymes in IBS. So let's get into the type of patients to consider using digestive enzymes for FODMAPs with. It can be helpful to return to this framework as we think about who may be suited to a low FODMAP diet and who may benefit from a less restrictive approach, like enzymes. All patients who are FODMAP sensitive can benefit from enzymes, so it's often a question of when in the care process you might want to introduce them. There's no hard and fast rule on who to use digestive enzymes with or when, but these are a couple of patient populations that you would want to consider using digestive enzymes with as a first-line intervention. A lot of these patients are the same as those who we saw are contraindicated for a low FODMAP diet. So some patients to use enzymes with would be those already on a highly restrictive diet, such as for another clinical condition or due to food preferences. Patients with a history of disordered eating or who are at risk for disordered eating are also often candidates for enzymes early on in the care process. Patients who lack access to low FODMAP foods or would have trouble preparing them, as well as those with poor compliance to diet recommendations, can also find enzymes valuable. And lastly, patients who are elderly or at risk for malnutrition can often benefit a good amount from using enzymes ahead of any serious diet change. So these are just some examples, but at a high level, enzymes really can help liberalize the diet of anyone with sensitivities to the FODMAP that the enzyme targets. I'm often also asked when during the low FODMAP diet or when in the general IBS treatment process to use enzymes with patients. So when it comes to when and how to get patients started, we can also return to this conceptual framework on how to assess patients for a low FODMAP diet. Broadly speaking, there's two common scenarios here, and enzymes can be used with or without dietary change based on a patient's indications and their awareness of their FODMAP triggers. On the left here, digestive enzymes would be used prior to or in lieu of a traditional low FODMAP diet in a couple scenarios. Some patients may be able to identify high FODMAP foods as triggers, such as garlic, onion, wheat, and beans, without needing to implement an elimination diet. Or sometimes during your intake, you'll be able to tell that they're eating a lot of high FODMAP foods and reporting symptoms consistent with FODMAP intolerances. So in these instances, digestive enzymes can be used with their known or those highly suspected triggers to validate a FODMAP intolerance and also learn if and how FODMAP-targeting enzymes can provide symptomatic relief against the FODMAPs. With these patients, there's often little need for a highly restrictive diet and going through all that dietary burden to really learn what they already know. And enzymes can likely provide immediate relief before, or sometimes even without needing much diet change after that. Then moving to the right here, if enzymes are used with dietary change, it would be with known FODMAP triggers during the personalization phase and for long-term maintenance. In these cases, enzymes can help further liberalize a patient's diet and help them enjoy the many more FODMAP foods they might not otherwise be able to tolerate. What you want to avoid is using enzymes during the phase 1 and 2 of the low FODMAP diet. These phases are really about learning personal FODMAP triggers and tolerance levels, so adding enzymes in either phase would make it hard to tell what the patient is able to tolerate. So it will take your clinical judgment to assess when and how to incorporate enzymes into a patient's care plan, depending on their indications and interests. But I do hope this provides some of a helpful starting point to more confidently identify when and how to use enzymes with patients based on how they're presenting. The next topic I want to dive into is how to select an appropriate enzyme for patients to try. First and foremost, you always want their known or suspected FODMAP triggers to guide selection. So for example, in the case of a lactose intolerance, you'd use lactase to help patients tolerate milk, ice cream, and yogurt. For fructan intolerance, a fructan-targeting enzyme will help patients enjoy garlic, onion, wheat, Brussels, and other high fructan foods, and so on. Patients with multiple FODMAP intolerances can often benefit from a combination enzyme blend, which will target several FODMAPs. We know that most meals contain more than one FODMAP, so for patients with these multiple FODMAP sensitivities, a combo product can help in streamlining what they need to take at each meal. I also want to mention enzyme activity here, because there's no hard and fast guidelines on recommended activity units for these enzymes, and research studies often do look at varying doses. In practice, most enzyme products that are specifically for FODMAPs and clinically backed will have sufficient enzyme amounts. What you want to watch out for are broad spectrum enzyme cocktails that are not specifically for FODMAPs. These products can often inflate their formula with a lot of enzymes that are not actually targeting real triggers for patients. And this will mean that they may have really small amounts of the FODMAP targeting enzymes in their blend. Also, and I'll get to this in a moment, enzyme activity is just part of the picture when it comes to efficacy. The other factor to think about is mode of administration, or how the enzymes get used or taken with the food, which also matters a lot when it comes to efficacy. And what about polyols? Sadly, there is no enzyme yet that targets polyols, but I do want to share several lifestyle and diet tips to help patients at least do what they can to support polyol tolerance. So, first, we want patients to be mindful of portion sizes and their personal tolerance levels for polyols. It's also common that patients will have different tolerances to mannitol, one type of polyol, than they might to sorbitol, the other type of polyol. So, do what you can to help them learn if it's all polyols or just some that are triggers for them so that they don't end up overly restricting. We want to encourage patients to also have polyols and polyol-rich foods in the context of a larger, more balanced meal if they are going to include polyols in their diet. This can also help mitigate some symptoms compared to if they were to eat the polyol food alone. And lastly, patients can also use digestive enzymes for other FODMAPs when having a multi-FODMAP meal. This would help limit FODMAP stacking, which reduces the overall FODMAP load, even though the polyols themselves would still be present. And now let's get into that question of mode of administration, which matters significantly when it comes to efficacy. Over-the-counter carbohydrate targeting enzymes, like those for FODMAPs, begin working on the food as soon as they come into contact with it. So applying enzymes directly to food creates maximum homogenization between the enzymes and the FODMAP-containing foods they're aiming to break down. The reason why this is so important lies in the mechanism behind which enzymes act to actually break down FODMAPs. The enzymes are acting on the food, not the body. So we want there to be as much contact between the enzymes and the food as possible. This concept is similar to the way in which salivary amylase get worked into the food matrix through chewing, peristalsis, and the churning action of the stomach. FODMAP-targeting digestive enzymes that are delivered in a capsule or pill end up actually separating the enzymes from the food they're meant to break down, and their enzymes can lose activity before they've had the chance to act on the FODMAPs. Another question I hear is whether stomach acid will affect the enzymes and their efficacy. This gets a bit nerdy, but what's interesting to know is that over-the-counter digestive enzymes actually favor the slightly acidic gastric environment and work best at a lower pH, like that of the stomach. This is different from prescription enzymes, which are encapsulated to delay release until they reach the small intestine, where they're designed to act. These prescription enzymes, which are used when a patient's production of endogenous enzymes is deficient, favor the more basic environment of the intestine, so that's why they're encapsulated. And just as a practical tip for you and your patients, some products will come as a powder, while others may come in a capsule. If patients purchase those in a capsule, they can usually just open up the capsule and sprinkle it on the food. So in summary, here's a recap on what to look for when selecting an appropriate enzyme to use with patients. First, always look for a formula that will target a patient's known or suspected FODMAP triggers. When it comes to over-the-counter digestive enzymes, recommend that they use enzymes in a powder form, which allows for maximum contact between the enzymes and their FODMAP target. Always seek a clean label to make sure that there aren't other gut triggers in the product. Avoid supplements that contain ingredients like mannitol, sorbitol, lactose, emulsifiers, or artificial sweeteners, which can trigger symptoms themselves. And lastly, seek a formula with scientific backing and look for products that have peer-reviewed research on the product itself. So what should your patients expect when using enzymes? This is really what makes me so passionate about sharing on this topic. Enzymes provide support in many ways and really are so versatile. First, for patients who are FODMAP sensitive, they're going to support better digestion of trigger foods and reduce overall FODMAP load of a meal, which helps manage symptoms. This control over symptoms means digestive enzymes can also be monumental in reducing fear and anxiety around food. Especially when it comes to social eating scenarios, enzymes can be hugely helpful in allowing patients to enjoy the communal and cultural aspects of food and reduce anxiety around anticipated symptoms in these scenarios. Plus, enzymes enable more dietary flexibility and the ability to follow a more nutrient-rich diet. I want to elaborate on these nutritional benefits briefly because there are so many. FODMAPs, again, are found in lots of fruits, vegetables, whole grains, and dairy. By allowing patients to include these foods more liberally, enzymes can reduce the risk for nutrient deficiencies. For example, with lactase, patients are able to include more dairy foods, which can increase calcium intake and support bone health. High FODMAP foods are also often fiber rich, so a low FODMAP diet may reduce fiber intake. Using enzymes with plant-based, fiber-rich foods helps patients tolerate these foods and over time increase their fiber intake. Plus, many FODMAPs deliver prebiotic benefits, which provide particular support for microbiome health. We know a high-fiber diet is preventative against many other GI conditions, so the role enzymes play in helping patients meet fiber recommendations is really significant. And lastly, many plant-based or non-meat protein sources are high FODMAP. These include foods like tofu, peas, legumes, nuts, soy, and dairy. Enzymes help patients get more plant-based protein with fewer GI symptoms. In particular, for your vegan and vegetarian patients, this can be a really important benefit to emphasize and help them take advantage of. So when it comes to introducing FODMAPs with the help of digestive enzymes, start gradually and introduce one FODMAP at a time to monitor symptoms. Once patients have identified a couple high FODMAP foods they'd like to try tolerating with enzymes, encourage them to set up a low-stress meal or eating scenario to try them out. For example, if they're headed on vacation and want to use enzymes to tolerate foods when traveling, make sure they first try enzymes with a few meals at home ahead of the trip. Make sure patients are also using the enzymes as instructed. So have them take the enzymes with the high FODMAP meal, either with the first few bites or mixed in. A common issue I see is that patients take them too early or forget and take them after a meal, which will reduce the efficacy of the enzymes. It's also common for patients to want to take them with water, but this is also not recommended since it will reduce the enzyme's ability to come into contact with the food. In terms of assessing response, patients should expect to see a benefit roughly 4 to 8 hours after a high FODMAP meal, which again is generally when FODMAPs tend to reach the colon and trigger distress. Though for some patients, it may be a little bit sooner than that 4-hour mark or maybe a little bit later than 8 hours. If their typical symptoms improve following an otherwise triggering meal, this signals that digestive enzymes can support greater FODMAP intake and a less restrictive diet. The specific improvement in symptoms will be based on how each patient typically respond to FODMAPs. Some tend to feel more bloated and gassy from FODMAPs, while others might tend towards diarrhea or constipation. So the specific symptom benefits will vary case by case. Frequency of use will also depend on personal tolerance and personal FODMAP triggers. Know that enzymes are highly safe and can be used as frequently and for as long as FODMAP intolerances persist. Enzymes, again, as specialized proteins, will be metabolized as any other dietary protein would be. So in the case that they do not come into contact with a carbohydrate to break down, they'll simply get metabolized and excreted. They don't enter circulation in the body or remain in the body at all. Okay, so this is all great, but what about the patient that is not seeing benefit? Here are some common troubleshooting tips I thought I'd share. Before we even get into these tips, though, I want to mention another common question that might come up, which is any adverse reactions to enzymes themselves. Assuming a patient is using a so-called clean formula that's free of other potential digestive triggers, shifts in bowel patterns with enzymes are generally related to changes in their overall diet rather than the digestive enzymes themselves. You could probe into potential allergens in any stabilizer or other ingredients that an enzyme has, such as corn or other starches, but mostly you'll want to consider how their diet has changed now that they're eating more FODMAP-rich foods. So, The first area to probe into is fiber intake. It's great that enzymes allow patients to enjoy a more diverse range and quantity of fruits, vegetables, nuts, and whole grains, which helps, of course, increase their fiber intake. However, this extra fiber can also trigger digestive symptoms if not added gradually and with care. So you could discuss fiber manipulation with them, which refers to changing the texture of the fiber containing food itself to a more tolerable form rather than changing the amount or type of fiber. Some examples of lower roughage yet high fiber foods to suggest would be a butternut squash soup that's pureed versus whole pieces, maybe a fruit or veggie smoothie versus a whole fruit, hummus or baba ganoush, creamy cashew or almond butter versus the nuts themselves. Those are just a couple examples, but what we want to remind patients is that when they're adding fiber, you want to be mindful of how quickly you're increasing your overall fiber intake on a day-to-day basis, as well as the different types of fiber and the form in which it's coming in the food itself. On top of that, we also want to remind patients that it takes time for the digestive tract to adapt to a high fiber diet, and really need to emphasize the importance of hydration in supporting fiber tolerance. Patients can also be very eager to add back in foods they've been missing, which may lead to large portions and meals. Always encourage them just to be mindful about this and tune into their hunger and satiety cues to avoid overdoing it and triggering symptoms. And then always discuss potential other triggers in their diet that they might want to avoid or limit depending on what their personal sensitivities are. So, some categories to probe into here might be fatty or spicy foods, alcohol, caffeine, and carbonated drinks or artificial sweeteners. So, this is just a starting point on areas to probe into with patients who are not seeing the benefit they'd expect with enzymes. These are some of the most common issues I've seen, but it's certainly not exhaustive. I also want to touch briefly on how to support patients who may be reluctant to add back in trigger foods, even with enzymes. In general, patients often fall into two categories: those who learn about enzymes and are gung ho to eat everything they've been missing, and then those who are still fearful and reluctant to add more foods, even with enzymes. So, here are a couple strategies to support patients who do harbor strong food fears and anxiety. First, it can be helpful to provide education on the link between excessive dietary restriction and GI therapeutic diets, just to remove stigma and open up the conversation around their anxieties with reintroduction. Research shows that those who have been on a restrictive diet, such as low FODMAP or gluten free, are 3 times more likely to show behaviors of excessive restriction. So you're not trying to scare them or anything, you just want to help put into context that they're not alone and it's by no means their fault. You also may want to help them understand what falls in this category of excessive restriction and help them do some self reflection on where their anxieties around food may be coming from and if they're truly warranted. Dietary restriction is a routine part of care for many GI conditions. So, what we want to do is help them understand if their restriction is going beyond what is needed for symptom control. Some questions to probe into here would be the level to which they avoid foods or eating due to fear of GI discomfort, maybe if they're having difficulty socializing due to dietary restriction, if they've lost pleasure or interest in food altogether, or how frustrated they may be with their restrictive diet. If they're tending toward a yes on a lot of these questions, you'll want to spend some time with them to work through how this restriction might be impacting them. This can often be a way to help them build motivation towards adding more foods into their diet. The discussion can really be open-ended. Your aim for the conversation will generally be to simply explore their relationship with food and the behaviors they have around it. This can also be useful to help them develop self-awareness around the benefit they might stand to gain from adding in more foods. So this just touches the surface of all the counseling strategies that might be helpful with your patients who are anxious about reintroductions. There are a lot of great resources out there for counseling on disordered eating and GI that I really encourage you to look for if this is a relevant topic for you and the patients you're seeing. And on the flip side of that, you will also likely see many patients that are eager to dive right in and try digestive enzymes. Here are common questions that patients often ask, and a few pieces of advice I thought I'd share with you for these discussions. One question that can come up is whether patients can now eat whatever they want with enzymes. Here, it's helpful to first remind them about how enzymes are specific to their substrate. So, if you're using an enzyme for one trigger, say GOS, the enzyme will only help with foods high in GOS. There's also often value in explaining the concept of a quote FODMAP bucket, which generally refers to the dose dependent nature of FODMAPs. We know our patients may tend to think in black and white, but the reality is that FODMAPs will trigger symptoms when they're eaten in quantities that surpass a patient's personal tolerance threshold. So, one way to explain this is by saying that enzymes can help decrease the amount of FODMAPs in that overall bucket, which often means they can then tolerate either more and different FODMAPs, or they may be able to tolerate other digestive triggers altogether. But no, enzymes do not mean patients all of a sudden have a free pass. They still should aim to have balanced, regular meals. You might also get asked about what foods have FODMAPs in them. This would be particularly common if you're using enzymes with a patient who hasn't done a low FODMAP diet in the first place. My recommendation here is to first start by discussing their current diet and talk about what they're typically eating, as well as the foods they've maybe cut out but miss a lot and hope to add back in. Then, based on this discussion, you can put on your quote FODMAP lens to identify which of these foods are high FODMAP and recommend that patients first try enzymes with these foods or meals. This can be a lot less overwhelming and more practical than providing a generic list of high and low FODMAP foods, which may or may not be relevant to that patient. I'll also share that the Monash and FODMAP friendly apps can be helpful for some, but they can also provide a bit too much detail and create some obsessions around food. Especially if you're noticing some red flags with patients around disordered eating or food fears, really try to start with a personalized approach based on the patient's current diet and suspected triggers, rather than pointing them first to these highly detailed FODMAP apps. Another question you might hear is about whether patients can cook with enzymes. The point to emphasize here is that enzymes deactivate at very high temperatures. So enzymes can be mixed into food once the dish has cooled to a comfortable eating temperature. However, this is even a bit more nuanced than just temperature, because mixing enzymes into food would only apply to dishes or ingredients that are a homogeneous texture. So dishes where the enzymes can freely mix with food, like smooth sauces, pureed soups, hummus, smoothies, and other drinks, would all be okay to mix the enzymes into in the kitchen. But you wouldn't want a patient to say add enzymes while they're sauteing garlic or stewing beans, since the enzymes would be deactivated by the high heat before they've had the chance to break the FODMAPs down. And then returning to that concept of smooth versus solid foods, you also wouldn't want a patient to add enzymes to the top of a dish that's a solid food and then let it sit without being mixed. And when I say solid food, I really mean anything that requires chewing, like a chunky soup, sandwich, pasta, or something else that's not smooth. The reason why we wouldn't want patients to add enzymes to these solid foods and then let them sit for a while is because the enzymes are activated once they come into contact with the food and will begin to lose their activity over a period of time. So if they put enzymes on a pizza in the kitchen, then come back an hour later, the enzymes would no longer be active and wouldn't provide any support against the FODMAPs in the pizza. This is because for FODMAP-targeting digestive enzymes, the real window of opportunity to create that homogenization between the enzymes and FODMAPs is 30 minutes following their first interaction with food. So that's why when it comes to these solid food dishes, we really want patients to use enzymes with the first bite of the meal or the first few bites, so that as they're chewing and their stomach is churning, the enzymes get fully integrated with the food. Another question I often hear is, will my patients become dependent on enzymes? To answer this, it's helpful to think back to why FODMAP intolerances are present in the first place. It's not from a lack of endogenous production, but rather other factors like miscommunication between the gut brain axis, visceral hypersensitivity that's leading to these heightened sensations around digestive processes, or alterations in the gut microbiota that are leading to FODMAP intolerances. So, enzyme dependency is not a concern because the FODMAP intolerances are not due to a lack of endogenous production in the first place. I will say, however, that the factors that may be leading to the intolerances in the first place can evolve. So, their stress levels may change, the composition of their gut microbiota can evolve, and their level of visceral hypersensitivity may go up or down as they develop more coping skills. So, patients may find they increase or decrease their enzyme use based on how they're tolerating FODMAPs at any given time, because all of these background factors will naturally be changing. And then lastly, the question of cost can often come up, particularly since digestive enzymes for FODMAPs would be over the counter and therefore paid out of pocket. A consideration to talk through with patients here would be the cost difference between enzymes and low FODMAP products or dietary swaps overall, since we know the cost of buying specialty foods can add up. Enzymes are also the kind of tool where patients should be able to understand if they're working relatively soon after starting. So they can buy just a week or two supply, and after using that amount consistently for a week or two, they should have a good sense of if the enzymes are working for them. Then after that, they can make a call about long-term use. This is pretty different than a probiotic or some other supplements where it might take months to tell if they're working, and that's assuming they're able to tell at all. And then lastly, a lot of patients in the US will be able to use HSA or FSA funds, so pre-tax dollars, to purchase products. You can encourage patients to look into that option if this is a benefit that they have from their employer. And now the fun stuff. We've been speaking really abstractly about FODMAPs and food, but here are just a few common actual meals where enzymes can be really handy. A lot of classic, nostalgic dishes in many cultures are high FODMAP, from a traditional meatloaf with gravy to falafel and pita or different types of stir fries. Enzymes can open up many delicious options for patients. A lot of these dishes might not even be possible to recreate a low FODMAP version of, or would take a lot of modifications to make low FODMAP. So, nutrition benefits aside, yes, it's great that enzymes allow patients to get in more fiber and fruits and vegetables, but enzymes can also be really impactful when it comes to plain old quality of life. They can make following a balanced diet and managing GI symptoms more sustainable for those with IBS and reduce a lot of stress that would otherwise get in the way of enjoying food. Patients can use enzymes and go about their day to day life and get back to socializing around meals with much less worry and planning. So, to wrap up, I will just underline how the pathophysiology of functional GI disorders is incredibly complex. Effective management can often require both dietary and non dietary lifestyle strategies to manage symptoms. What we want to do is help patients develop a long term, sustainable plan that helps them manage symptoms without excessive burden. It often takes different tools to help keep symptoms under control, and the right combo of what works will look different for each patient. Digestive enzymes can be a very powerful and versatile option to help patients build a diverse diet and enjoy the many social and cultural pleasures of food while also managing symptoms. I hope this helped you learn a bit more about how to assess patients for FODMAP intolerances, how digestive enzymes work, and how to use enzymes with patients. Working in the GI nutrition space requires a lot of clinical judgment. We know our GI patients are highly complex, and it's rarely just one condition they're managing. I've specialized in this field because we know how much patients really need tools and interventions to help manage symptoms that don't just recommend cutting out more foods. So I hope this webinar helped you feel more confident in your understanding of how digestive enzymes work and which patients they may be able to help. Here are references from today's presentation. Here are references from today's presentation. Here are references from today's presentation. So thank you again. Please do reach out to me with any questions or feedback. I'd love to connect with you. So thank you again. Please do reach out to me with any questions or feedback. I'd love to connect with you. So thank you again. Please do reach out to me with any questions or feedback. I'd love to connect with you. So thank you again. Please do reach